Start the session. We have Edsel Salvana. So Edsel is one of the top infectious disease specialists in the Philippines. He's going to give us a brief overview of the current epidemiology of COVID-19 in the country. Edsel, the floor is yours.
Okay. Good morning, everyone. Thank you to PAASE for the opportunity to present an overview of what's going on in the Philippines. And as you know, this has been going on for a while now, since January. And this is just really kind of a snapshot of what's going on, and a little bit about what's going on in terms of transmission and some of the genomic work that's happening at the Philippine Genome Center in RITM. So just very briefly, our first cases in the Philippines started towards the end of January, and these were all imported cases from China. At that time, we eventually shut down borders with China, and these patients, it did not look like there was forward community-based transmission, because there was a lot of surveillance at that time, and it took about more than two incubation periods before the next cases came in. So epidemiologically speaking, those first three cases were distinct, at least from those first three cases in January. The first death outside China, unfortunately, did occur in the Philippines, and this was one of the three Chinese nationals. He also had influenza and strep pneumo on top of the COVID, and we think that that's why he died, aside from some of his comorbids. In March, the start of March, we had two new cases. One was imported from Japan, and the other one was the most concerning one, because he did not have any travel history or a known contact with a positive case. And at about 10 cases, this is when some of us on the technical advisory group of the IATF already urged the government that if we found one that looked like it was community transmission, we should think about closing down. At about 52 cases, we actually declared GCQ and DCQ right after that. In early March, we peaked at 538 cases, and then the cases started slowing down, although there was a lot of delay in testing as well. And then as the cases started to decrease on daily cases, and there was an indication of a slowing down, then ECQ and GCQ were modified. In June, we saw a second epicenter occur in Cebu. There was also more expanded testing, so the cases were also going up due to expanded testing, but even correcting for that, there was really an increase in cases. And in July, the cases continued to increase. The Cebu cases have actually started to decline. That's why they were able to go down. NCR continues to rise, and the concern really is that our healthcare capacity is approaching critical levels. Available meds right now, just as a snapshot, we do have remdesivir, tocilizumab, favipiravir, dexamethasone, high-flow cannulas. We're no longer using hydroxychloroquine or lopinavir, ritonavir, just in case that comes up later. So from yesterday's number, we have 85,486 cases in total. 90% of these are mild. We have about 56,000 active cases right now. Every 15th and 30th of the month, the DOH actually cleans up some of these cases as recoveries if they've been on the board for more than 4 weeks and we knew that they were mild. A lot of those automatically get assigned to recoveries. So there's probably going to be more recoveries later, is what it's going to look like. Again, the cases last week, they were breaching 2,000 almost every day. But now we've had 1.6, 1.8, and now hopefully we start to see a slowdown on these. Again, a lot of these are delayed as well because it comes from all over the country. And on top of that, you also have some of the labs reporting late. And you can see the recoveries that are written there as well. Now, NCR capacity is getting worse, and we can see this on the ground for those of us who are in hospitals. And even the ERs are starting to fill up. So we really need to increase our capacity at this point. And if you smoothen out the numbers, because some of these are delayed, this is confirmed COVID cases by date of illness. You can barely see the January 16 to 31 over there, but the rest, you can see there was a real increase. From March to June to about end of May, you can see the NCR numbers, which are green, were fairly flat, and then started to rise up again. But the initial increase in cases in May was really driven by cases from Cebu. Just a weekly snapshot of it, and you can see again that right now NCR seems to be driving a lot of the cases, and the blue region, which is mostly driven by Cebu, is starting to go down. And also, if we look at it by region, you can see that NCR still has the bulk of the cases. Visayas had that blip, but again, it's starting to go down. And then Mindanao has actually had a slow rise. And just looking at cases by sex and age, you can see that most of the cases occurred between 20 years old and about 50 years old. Now, some of those may be artifacts as well, because if children and younger people don't have very severe disease, or if they're asymptomatic, they're less likely to be tested. But you can also see that the ones who died were in the upper age groups more than the lower age groups. And if you look at the graph at the bottom, you can see that the deaths actually have a bimodal distribution. The deaths peaked early on in March and then came down, and then peaked again, and now it's going down again. But with this increase in healthcare capacity, I'm pretty sure it's going to go back up again, unfortunately. And just case fatality rates, you can see this is consistent with what's in literature. Above 70 years old is really kind of a horrific number of a percentage of deaths. They do not do well, and it's just like SARS when we're talking about older age groups infected with COVID-19 in the Philippines. And testing has actually improved. Even the backlogs are getting less. Where they've tested more than 1.3 million samples, but understanding that these tests are not perfect. PCR using nasopharyngeal swabs is about 62% sensitive on the day of onset of symptoms, and is about 80% on the third day of symptoms, and it just goes down after that. So we may not be capturing everyone. You can see that the positivity rate was pretty high at the start of the epidemic, and this was because we had very little testing available and we were prioritizing symptomatic patients. It went down and then has slowly gone up again, and it's about 9% at this time. Just a little bit about what's going on in terms of the genomes. This is from NextTrain, and I talked to Dr. Saloma, and she said that this is not complete that's in NextTrain because they have an algorithm that actually samples what's in GISAID. So what's in NextTrain here is about 10 whole genome samples from the Philippines, and you can see that there were about 8 samples around March, and to the right is the samples that came between June and July. And you can see that there was some clustering in the samples between March and April, but there's actually that kind of an outlier on top over there with the 20B clade. That's more of a European clade, and we'll talk a little bit about that since I still have about 6 minutes. So just looking at that 20B clade that was sequenced sometime in June, I'm not 100% sure if it was collected in June, but that's when they sequenced it. And so the provenance of this one actually seems to come from Germany. So this is the first European origin whole genome sequence that they reported in June. If we look at the others, there was that clustering early in March, and then there's another one above that you can see. And then there are 2 sequences that seem to be related, one from March and one from June. And this might actually is probably a community transmission that continued in the Philippines because they're so close together. But you can see that there are different clusters that have been seen in the Philippines. And this is consistent because we have a lot of OFWs coming in on top of local community transmission. So there, aside from the first one in January, and then the Japanese and the local transmission, wherever that came from, there have been subsequent waves of establishment of these viruses, particularly because we've had more than 80,000 OFWs come in. The early ones, including the second sequence from January, from June, actually seemed to have an Indian origin, and of course this came from China. Again, with the algorithms of NextStrain, there are some limitations because they switch out some samples because there's a maximum set number of samples per country. And so in the past, this is actually also clustered to Japan, then India, or Australia, then India. But right now, the clearest one is China, India, Philippines. And again, this might be just a bioinformatics artifact more than anything. But these are the closest related samples to that, to those 9 other Philippine samples that are in NextStrain, aside from the one that looks like it came from Germany. Now, there's an interesting paper that came out that I think that is actually very controversial, and this is the shift of the mutation D614G, which is on the spike protein that supposedly makes SARS-CoV-2 variant more infectious. And there's a couple of reasons they thought about this. Is first that they saw a global transition in most of the sequences from D614 to G614, to the point that about 95% of the samples that they're sequencing all over the world in June to July is all G614. The second is that they've actually seen lower RT-PCR CTs for G614, which translates to higher viral loads in patients. And this looks like it might be a fitness advantage. There's no evidence that it's deadlier, but it may actually be more infectious. And they actually did pseudotype virions, and the virologists in the group can explain this better. But my understanding is that they basically mixed the G614 spike protein onto a different kind of virus, and they used it for experimental infections in mice, and they found the pseudotype virions with G614 variant were more infectious and grew to higher titers. This is because G614 seems to stabilize the spike protein. The D614 seems to break off easily, and G614 seems to stabilize that so that it gains entry into the cell easier. So you can see that if you look at the G variants, there is one that is found in NextStrain in the Philippines, and that's the one that came from Germany. All the other ones were D variants. But again, this is 10 sequences. And in June, one sequence was D and the other sequence was G. And my understanding is Dr. Saloma and the PGC group have actually seen a lot of G variants as well in the newer samples using partial genome sequence for the spike protein. Now, just this is going to be a quick video that will show you how the blue, which is D, becomes eventually replaced by G. So watch out for the brown to start coming in. This is about a minute. You can see above there's like the timeline, January going to February. And then you can start to see that some of the brown stuff is showing up in North America as well as Europe, and also starting to even get into Australia and even Malaysia. And now you're seeing South America turning brown. And this is, as we go on in March, it's almost completely replacing the blue-green D variant and is turning it into the G variant. And as we go further, you can see almost all of the infections, even ones in China, are now G variant because they're being imported back into China after it mutated. Now you can see that there's almost, and now Philippines has half, because in June we only had 2 sequences in NextStrain, and one was a D variant and one was a G variant. So this goes through, and now you see almost everything is G. So it's very concerning. And if this is indeed more infectious, as has been suggested by the Cell paper, then we're really in a lot of trouble. So in summary, the Philippines has had an initial cluster of cases in January, followed by sustained community transmission in March. And there was a major surge in cases that was mitigated by ECQ. The estimates of the World Bank are that we were able to avoid 1 to 3 million cases and about 100,000 deaths. Unfortunately, this had severe economic consequences. The case fatality rate has been improving. It's about 2% right now. We hope that it's going to keep going down. The cases, unfortunately, are surging anew as we open up. There's a second epicenter in Cebu, but most cases are still in the NCR. The G614 may be more infectious, so we're getting hit with a double whammy. We're opening up, and then we have the G614 here in the Philippines. And so, it doesn't spell good news for our healthcare system, and we have to do better with other things that we can do that don't have such a major impact on the economy. We really have to maximize our prevention measures, rationalize testing, increase tracing and isolation efficiency. We need a vaccine, but in the meantime, actually treatment is getting better. And the goal is to preserve the healthcare system and keep the deaths low at this time. Thank you very much.
And so thank you very much for that very interesting talk. I just would like to remind everyone, please post your questions in the Zoom group chat. We'll have a question and answer portion led by Maima Albaida, my co-host, after the first 3 talks. So I'm already seeing a couple of questions come up. Please continue typing them and we'll address them after the first 3 talks.